Good afternoon, everyone. iTech India welcomes all the participants to today's RDLS session. Today's topic is HIV and malignancies, and the speaker is Dr. Rajeeb Desar. Dr. Rajeeb Desar is a technical specialist public health with iTech India. We welcome you, sir, for today's session and request you to start the session.
Thank you, Swetaji, and good afternoon to everyone. So, this is found in the chapter number 5.6 of for HIV care and treatment 2021. Now, this is taken early National Digital Learning Seminar Series by different speakers earlier. So today's discussion would be basically a recapitulation of that. And this topic is a huge topic. We are going to cover it in the following sections. So introduction, then Kaposi, systemic age-related non-Hodgkin's lymphoma, DLBCL, Burkitt's, primary CNS lymphoma, primary fusion lymphoma. So with penis precancer and cancer. So basically, is working in the field of HIV. For us in the ART center, it is very, very important to know the different kinds of malignancies that are in HIV, and those malignancies that mimic some of OI, like tuberculosis, how to differentiate them. And we also need to know the kind of chemotherapy these are available, or the preferred chemotherapy these are for a particular malignancy, so that we can limit drug-drug interaction with ART and chemotherapy, and we can prevent renal toxicity and hematotoxicity in such a patient. And it is also a good practice to take the advice of SASAP in those cases. And we should basically coordinate between the SASAP and the oncosurgeon and oncologist. Know those regimen and how do they interact with the ART, different components of the ART, and the malignancies which are more common with lower CD4 count and which are less common in with more, higher CD4 count. Those things we need to remember in order to have the differentials while diagnosing a case, and after diagnosis, we need to promptly refer them to the oncologist. And in cases where required, we should also send the patient to SASAP. Now, coming to the subject, HIV is an increased risk factor for development of many malignancies. Kaposi sarcoma and high-grade B-cell non-Hodgkin's lymphoma and invasive cervical cancer have been designated as age-defining. Cancer account for approximately 1/3 of all death in PL-HIV. HIV patients have a higher risk to die from a tumor than from AIDS-related infections. And non-Hodgkin's lymphoma is the most frequent event in such a case of mortality. Now, coming to Kaposi. So, Kaposi sarcoma is caused by Kaposi sarcoma herpes virus, and lesion appear most often in the lower extremities, face, especially nose and genitalia, with the hues including pink, red, purple, and brown. And it may be ulcerated. It may be fleshy. Now, diagnosis is usually clinically by its characteristic appearance. However, for confirmation, we need examination. Extracutaneous spread is seen in 1/3, with oral cavity 15%, GI tract 40%, and pulmonary and lymph node involvement is also there. Occult blood in stool is an excellent screening modality, and a cherry red nodule on bronchoscopy is a strong suggestive of the diagnosis. So cherry red is found in the bronchoscopy, and occult blood in the case of involvement of the GIT. Now, staging, histopathological grading of Kaposis can be either a patch, plaque, or a nodule, and risk stratification is based on tumor stage, that is T0 or T1, and immune status I0 or I1, and systemic illness SO or S1. Now, staging of Kaposi sarcoma includes a complete inspection, including oral and genital mucous membrane, an abdominal ultrasound and chest radiograph to exclude pulmonary and GI involvement. Gastroduodenoscopy and colonoscopy should be considered when mucous membranes are involved. Now, the modified AIDS clinical trial group staging of Kaposi sarcoma, tumor T0, that is low risk or better prognosis. Kaposi sarcoma is only in the skin or in the lymph nodes, or there is only a small amount of disease on the palate, that is roof of the mouth, or the Kaposi sarcoma lesion in the mouth are flat rather than raised. So all these are basically a good prognostic feature, and we call it as T0. And poor risk, any of the following, that is tumor lesions are widespread, one or more of the following is present, that is edema or ulceration due to the tumor, extensive oral Kaposi, and lesions of Kaposi are in organs other than lymph nodes, such as lungs, intestine, liver, etc. And Kaposi sarcoma in the lung can sometimes mean a worse prognosis. Again, the immune status, I0 means good risk, that is CD4 count of more than 150 cells per cubic millimeter, and I1 means poor prognosis with the CD4 count of less than 150 cells per cubic millimeter, and systemic illnesses, presence or absence as 0 without any systemic illness, and no history of opportunistic infection, no B symptoms, that is lasting for more than 2 weeks, that is B symptoms, basically unexplained fever, night sweat, severe enough to soak the bed clothes, weight loss of more than 10% without dieting. Now, these B symptoms you will find in several places. So we need to remember this B symptom. These are basically unexplained fever, night sweat, drenching night sweat, weight loss of more than 10% without dieting, or lasting for more than 2 weeks. Now, Karnofsky KPS score of 70 or higher is a better prognostic one. Patient is up and about most of the time and able to take care of himself or herself. Now, this KPS you'll also find later on in relation to different malignancies. And poor risk is implied with S1 with a systemic illness. One or more of the following is true. That is history of opportunistic infection or thrush. One or more B symptom is present. KPS score is less than 70, and other HIV related illness is present. So any of this, if present, then it bears a poor risk or poor prognostic thing. Now, for local therapies, we may be most useful for localized KS, for localized bulky KS lesion or for cosmetic purpose, but does not affect the development of new lesion in untreated areas. So, alitretinoin of 0.1% is the only topical self-administered therapy approved for the treatment of Kaposi sarcoma. Now, patients requiring 4 to 8 weeks for clinical benefit, and dermal irritation can be a side effect of it. And dark skin people can develop lightening of the skin. And alternatively, local treatment can include intralesional chemotherapy, like vinblastine, and radiation therapy, laser therapy, and cryotherapy. And this vinblastine has an excellent response rate of 70% in case of localized Kaposi sarcoma. Now, systematic therapy, liposomal doxorubicin and liposomal daunorubicin are recommended as the first-line chemotherapeutic agent for patients with disseminated symptomatic Kaposi sarcoma. Recommended doses of doxorubicin is 20 mg per meter square every 3 weeks, and for daunorubicin it is 40 mg per meter square every 2 weeks. Paclitaxel at a dose of 100 mg per square meter every 2 weeks is the newest systemic chemotherapeutic agent approved for KS, and is recommended to be used in anthracycline-resistant disease. That is, those Kaposi sarcoma which are resistant to daunorubicin, doxorubicin, like anthracycline group of drug, then there we should use paclitaxel. Paclitaxel is not recommended to so in the treatment of Kaposi sarcoma, indefinite therapy is not recommended because of poor tumor response and drug-related toxicities. So this is how we can see the effect of treatment in Kaposi sarcoma on the left-hand side before the treatment, and on the right-hand side after treatment. So the raised edge bulky solitary Kaposi sarcoma is not there in the second picture. So the recommendation are local therapy or intralesional vinblastine therapy for symptomatic or cosmetic improvement can be given in early, that is T0 Kaposi sarcoma. Chemotherapy along with ART for T1 or advanced Kaposi sarcoma. Liposomal anthracyclines are the first-line chemotherapy for T1 advanced KS, and paclitaxel for the second-line treatment of anthracycline refractory Kaposi sarcoma. Come to systemic AIDS-related non-Hodgkin's lymphoma. PLHIV have an increased risk of developing non-Hodgkin's lymphoma. DLBCL and Burkitt's lymphoma or leukemia are considered age-defining illness. Despite the decrease in incidence of age-related lymphomas because of increased use of effective ART, ARLs have increased as a percentage of first ADI, that is age-defining illnesses. The development of ARL, that is age-related lymphoma, is characterized by advanced clinical stage, B symptoms, and extranodal involvement, including bone marrow, and has been shown to be related to older age, low CD4 count, and no prior treatment with ART. Now, lymphomas that are common in immunocompetent patients equally are Burkitt's lymphoma, diffuse large B-cell lymphoma, Hodgkin's lymphoma, and other lymphomas like MALT, lymphoma, peripheral T-cell lymphoma, and natural killer cell lymphoma. But the below box, that is lymphoma occurring more specifically in HIV positive patients are PEL, primary effusion lymphoma, plasmablastic lymphoma, lymphoma arising in human herpes virus associated multicentric Castleman disease, lymphomas occurring in other immunodeficient state, and polymorphic lymphoid proliferations resembling post-transplant lymphoproliferative disorder. So, coming to non-Hodgkin's lymphoma, we can see on the left-hand side, multiple bilateral, free, mobile, non-tender, and firm 1 to 3 centimeter lymph nodes with normal skin over the swelling in the cervical area. And in the X-ray, we find mediastinal widening due to multiple enlarged mediastinal lymph nodes. And the same patient actually showed in CT scan multiple nodes in left para-aortic, aortocaval region, small rounded hypodense lesion in anterior aspect of upper pole of right and mid pole of left kidney, lymphomatous deposit with minimal left pleural effusion. Diagnosis, apart from the usual blood tests, the evaluation and clinical staging of ARL requires CT scan, bone marrow aspiration, and bone marrow refined biopsy. PET scanning at diagnosis also improves the staging accuracy and hence the treatment accuracy. CSF examination is recommended if there are clinical signs of CNS involvement or paranasal sinus involvement, breast involvement is there, epidural or testicular involvement is there. Virological testing is also advised because these malignancies are associated with different kind of viruses that we'll see later on. In the DLBCL, it is immunoblastic Epstein-Barr virus 90% and centroblastic Epstein-Barr virus in 30%. Burkitt's lymphoma 25 to 40% Epstein-Barr. Primary CNS lymphoma, again, it is Epstein-Barr plus human herpes virus 800%, and primary CNS lymphoma 80 to 100%, plasmablastic lymphoma 90 to 100%, Hodgkin's lymphoma, Epstein-Barr virus 90 to 100%, and multicentric Castleman disease, herpes simplex virus, human herpes virus 100%. So, accepting this primary effusion lymphoma and multicentric Castleman disease, rest all are basically caused by Epstein-Barr virus, and multicentric purely human virus 8. And in primary effusion lymphoma, we can find both Epstein-Barr and HB. Now coming to DLBCL, is the most frequent ARL, often present at advanced stage and with the B symptom, and extranodal tissue is frequently involved, mainly in severely immunosuppressed patients. Prognosis determined by patient status, characteristics of lymphoma, and HIV specific factors. The International Prognostic Index, that is IPI, has been extensively outcome in case of DLBCL. Low CD4 count have been reported to be predicted.
Rajeev sir, please continue.
Screen is visible, no?
Yes, sir.
Okay. There are some internet issue, I think.
Okay.
So the low CD4 count have been reported to be predictor of poor survival in several studies, and we will see later on that in other many malignancies also, the CD4 count or immune status is very, very important to have a successful treatment of malignancy. So we need to put them on effective ART as soon as possible in most of the cases of AIDS-related HIV-related malignancies. Now, first-line chemotherapy for DLBCL is R-CHOP, that is cyclophosphamide, doxorubicin, vincristine, and prednisolone plus rituximab. This R is for rituximab. And the R-EPOCH, that is dose-adjusted etoposide, prednisolone, vincristine, cyclophosphamide, and hydroxydonorubicin plus rituximab. Now, these two regimen we need to remember, R-CHOP and R-EPOCH, because this will be encountered in different other malignancies also, and we need to know the side effects of each component of this regimen, and we also need to know how they interact with the ART specific ART molecules, so that we can limit the drug-drug interaction, drug side effect, and different toxicities, particularly renal and myelotoxicity. But ART, because of the current practice of test and treat, most of our ART PLHIVs are put on already ART, and because of that, they have better immune status nowadays. And immune reconstitution is also there, and hematopoietic growth factors availability also allowed us to use this conventional myelotoxic chemotherapy even in the presence of antiretroviral drugs. Now, treatment of DLBCL for localized one, that is with the stage 1 disease, we should treat with the combined modality treatment with 3 cycles of chemotherapy followed by radiotherapy, or 4 to 8 cycles of chemotherapy alone. For disseminated disease, either R-CHOP or DAR-EPOCH are advocated first-line regimen for disseminated DLBCL. A maximum of 6 cycles are to be given, or 2 cycles beyond documentation of a complete response. Different kind of responses that are seen in with the chemotherapy we'll see later on, and maximum 8 cycles can be given, 8 cycles of R-CHOP or DAR-EPOCH. Addition of rituximab to chemotherapy is now routinely recommended for DLBCL with appropriate antimicrobial prophylaxis and preemptive GCSF, that is growth factor, are to be given beforehand, before the development of myelosuppression. Now, in cases of relapsed or refractory diseases, treatment options for relapsed have been poorly investigated, and high doses of salvage regimens such as ICE, ifosfamide, cisplatin, and etoposide, DHAP, or dexamethasone, high-dose cytarabine, and cisplatin, or ECHAP, that is etoposide, methylprednisolone, high-dose cytarabine, and cisplatin, and GDP, gemcitabine, dexamethasone, and cisplatin with rituximab appears to have similar efficacy. Now, patients with chemosensitive disease who are eligible for transplant should proceed to autologous stem cell transplant. Now, the responses that we were discussing, a complete response means complete clinical and radiological disappearance of the disease, and PET scan is negative. Partial response means more than equal to 50% decrease in diameter of up to 6 of the largest dominant masses, and PET positivity in a previously involved site. But stable disease means failure to attain complete response or partial response. And relapse means a new lesions or increases a new lesion appearing, or a increase in size by more than equal to 50% of a previously involved site. So these are the possible responses to chemotherapy in DLBCL. So the recommendation are that R-CHOP and DAR-EPOCH are the first-line options for DLBCL. Chemotherapy should be combined with ART because improvement in CD4 count is seen to have favorable outcome for DLBCL. Closer surveillance is mandated for those with CD4 count of less than 50, and patients with relapse or refractory diseases should proceed to autologous stem cell transplant after high-dose therapy. PET scan should be performed at the end and after 4 to 6 weeks of therapy. Now, coming to Burkitt's lymphoma, it is the second most common subtype of ARL, occurs in individuals with relatively preserved CD4 count. Presentation is poor performance status and high lactate dehydrogenase level, and extranodal involvement is common, and the incidence of CNS involvement ranges from 8 to 28%. Treatment is basically Burkitt's lymphoma is Codox-M or IVAC. Codox-M or IVAC is basically cyclophosphamide, vincristine, doxorubicin, high-dose methotrexate, isosfamide, etoposide, high-dose cetarabine, and regimen consists of 4 cycles, each cycle lasting until blood count recover. That is, absolute neutrophil count should go beyond 1000 cells per cubic millimeter, and platelet count should go above 1 lakh cells per cubic millimeter. Cycle 1 and 3 involve Codox-M, and cycle 2 and 4 involve IVAC. 3 cycles of Codox-M are usually enough for low-risk patient, and for high-risk patient, receive 4 cycles. To overcome concerns of treatment toxicity in HIV-associated Burkitt's lymphoma, the DA-EPOCH regimen plus rituximab may be considered. Now, risk stratification for treatment of Burkitt's lymphoma: low risk must have at least 3 of these factors. That is, LDH is normal, stage 1 or stage 2 disease, WHO performance score of 0 to 1, and number of extranodal site less than equal to 1. And a high-risk disease, there is 2 or more of the factor on the right-hand side, that is raised LDH, stage 3 or 4 disease, WHO performance score 2 to 4, and number of extranodal site involvement is more than 1. And recommendation of chemotherapy is Codox-M or IVAC, and DAR-EPOCH are the first-line options for Burkitt's lymphoma. Chemotherapy regimen should be combined with ART. Now, prevention of secondary CNS lymphoma: use of intrathecal prophylaxis with methotrexate and or RRC have been long considered a mandatory part of the systemic treatment. Systemic treatment of all HIV-infected patients with aggressive non-Hodgkin's lymphoma. Advanced stage elevated serum LDH, extranodal disease, and involvement of testes, paranasal sinus, paraspinal location, breast, renal, epidural space, and bone predict a higher likelihood of CNS relapse. CNS prophylaxis should be reserved for those who need it based on site of involvement, stage, and histological subtype. Recommendations are that all patients with the DLBCL should receive CNS prophylaxis, intrathecal or IV methotrexate. All patients with Burkitt's lymphoma should receive CNS prophylaxis, either intrathecal or IV methotrexate. Tumor lysis syndrome. This is one of the very, very important phenomena occurring as a result of treatment of malignancy with chemotherapeutics, and we need to follow some good practices to prevent the occurrence of this tumor lysis syndrome. Patients that are at high risk for developing this TLS are those who are affected with the DLBCL, elevated LDH, bulky disease, and those with Burkitt's lymphoma with stage 3 or stage 4 disease. Treatment is aggressive treatment to prevent tumor lysis syndrome, include adequate intravenous hydration and rasburicase. The first dose of rasburicase should be administered 4 to 24 hours before starting chemotherapy. Rasburicase is given as an intravenous infusion over 30 minutes and should not be given as a bolus. This basically breaks down the uric acid so that it can easily be excreted by kidney. A repeat dose should be used if the serum uric acid level is above 7 mg per DL during the 96 hours after receiving the first dose of rasburicase. Those who do not meet the criteria for high-risk disease should also be adequately hydrated, although oral hydration and allopurinol may suffice. In those cases, we may not give rasburicase. Now, in the absence of any standard second-line chemotherapy regimen, various aggressive regimens, mostly containing platinum, have been tried in the treatment of refractory or relapsed cases of ARL. Commonly used regimen include DHAP, dexamethasone, high-dose cytarabine, and cisplatin, and ICE, that is ifosfamide, cisplatin, and etoposide. This is usually combined with rituximab, although the value of rituximab in those who relapsed earlier or are refractory to earlier treatment, it is not clear. For those who respond, studies have shown that consolidation with high-dose therapy and autologous stem cell transplantation is the optimal therapy for relapsed NHL. So the ultimate recommendation is those who are fit for intensive chemotherapy should receive a second-line regimen which may contain platinum. Those who achieve CR or PR with second-line regimen should be considered for high-dose therapy with ASCT, that is autologous stem cell transfusion. Coming to primary CNS lymphoma, that is PCNSL, it is a subtype of DLBCL with a post-germinal center phenotype confined to the craniospinal axis without systemic involvement. It can affect any part of the brain, leptomeninges, cranial nerves, eyes, or spinal cord. And presentation varies from subaquate focal neurological feature to 50% to neuropsychiatric signs, increased intracranial pressure, and ocular symptom. Diagnosis is done through serum LDH and CSF analysis should be done only when performed. Stereotactic brain biopsy is essential for a definitive diagnosis. The management of cerebral mass lesion in HIV patient includes a 2-week trial of anti-toxoplasma therapy prior to a diagnosis of PCNSL. So we need to remember that before the diagnosis of PCNLS, we should give a therapy of therapy for 2 weeks. Now, in radiology, we'll find the detectable Epstein-Barr virus in CSF and consistent radiological finding in severely immunosuppressed HIV-positive patient may be sufficient. MRI is the most sensitive imaging modality and shows single, that is 65%, or multiple lesions on non-enhanced T1 weight images, hyperintense tumor and edema on T2 or flare images, and densely enhancing masses after administration of gadolinium. So, treatment of primary CNS lymphoma are HIV positive patients with this PCNSL usually have advanced immune suppression and CD4 count of less than 50 cells per cubic millimeter, and making it impossible for the administration of high-dose methotrexate and cytosine rabinoside. High-dose methotrexate and rituximab appear to be a valid alternative. If induction treatment is well tolerated and a response is documented, then consolidation with high-dose therapy and autologous stem cell transplantation could be considered in selected patient. So the recommendations are that high-dose methotrexate containing chemotherapy regimen, combination with ART, and whole brain radiotherapy is a useful palliative treatment modality for control of symptom, or should be considered as an alternative first-line treatment modality in those patients where the risk of toxicity from high-dose intravenous agents are considered unacceptable. Now, coming to primary effusion lymphoma, it is a rare B-cell lymphoma characterized by effusion involving the pleura, pericardium, peritoneum, without identifiable tumor mass or lymphadenopathy. And it happens with severe immunosuppression, and the responsible virus is HHV8, and its presence is almost 100% present in 100% of cases. Presentation depends on the site of involvement. There is dyspnea in case of pericardial and pleural effusion, or abdominal distensions from peritoneal involvement. So diagnosis is analysis of the involved effusion fluid, which reveals the tumor cells that are large, have round to irregular nuclei and conspicuous nucleoli, and may have the appearance of immunoblast, plasmablast, and or anaplastic forms. Detection of evidence of viral infection is a pathognomonic thing of the diagnosis of primary effusion lymphoma. And immunohistochemical staging for latency-associated nuclear antigen, that is LANA1 expression, is the standard for detecting HHV8 in tumor samples. And treatment in the absence of any standard treatment for PEL in HIV should be treated with the CHOP regimen. Such treatment should be included as part of a clinical trial if possible, because there are no such documented preferred regimen. So they are recommending for CHOP, and we should include it as a clinical trial. And ART should be administered concurrently with such treatment. Plasmablastic lymphoma is a rare variant of DLBCL with plasmacytoid appearance, affecting primarily mucosal site of the oropharynx in males with HIV. The 3 histological subtypes include monomorphic plasmablast, minimal plasma affecting the oral cavity, those with more plasmacytic differentiation involving extra oral site right? Plasmablastic lymphoma involving nodes or spleens associated with Castleman disease. Diagnosis is immunohistochemistry, positivity for plasma cell markers, that is VS38C, CD38, multiple myeloma oncogene 1, and CD138. The constant presence of Epstein-Barr virus and the absent expression of CD45 or the B cell markers CD20, CD79, A, and PAX5 serve to distinguish plasmablastic lymphoma from immunoblastic variant of DLBCL, body and extracavity variant of PEL, Burkitt's lymphoma with the plasma cytoid differentiation, and extramedullary plasmablastic secondary multiple myeloma. So these are basically be done by the oncologist. These are expert thing. The specialist will classify and all. We need to know the diagnosis and the regimen that are being used in that particular patient so that we can tailor the ART to avoid drug side effect and minimize the toxicities. Now, treatment of plasmablastic lymphoma is CHOP-like treatment have been the standard of care. But due to disappointing long-term survival rate, more intensive regimen have been suggested. These are hyper-CVAD, CVAD, there is cyclophosphamide, vincristine, doxorubicin, dexamethasone, or Codox-M or IVAC, cyclophosphamide, vincristine, doxorubicin, methotrexate, ifosfamide, etoposide, and cytarabine. CHOP14, shortening the time between cycles from 21 days to 14 days has also been found to be effective in recent years. Plasmablastic lymphoma should be treated with intensive chemotherapy with CHOP14 as an option, followed by radiotherapy, at least in a localized stage. Early consolidation with autologous stem cell transplant might be an option for advanced stage disease, and the patient need to be put on ART. Cervical intraepithelial neoplasia, CIN, and cervical cancers. These cancers is very common in HIV patients with an earlier age of diagnosis, aggressive course, and poor treatment outcome. Cervicovaginal HPV infection has also been reported to be higher in HIV positive women, 62-65%, than in their HIV negative counterparts, where we find it is at 25% to 30%. ART has had a minimal effect on the incidence of invasive cervical cancer, but has effectively brought down the incidence of CIN in women with HIV. So we see here the cervical cancer is not dependent on the CD4 count. However, it has brought down the CIN, that is cervical intraepithelial with HIV. And diagnostic algorithm for cervical cancer. This is important for us, whoever is working in the field of HIV in ART center, because we need to refer the cases as per the algorithm. So visual inspection under acetic acid can be done at PHC. If it is negative, we can repeat after 5 years, and we should also provide them with health education. If positive, then we refer the patient to district hospital where PAP and VIA colposcopy will be done. And CIN on, if it is found to be CIN on colposcopy, then if it is suitable for cryotherapy, cryotherapy is given after punch biopsy. And if not suitable for cryotherapy, then the patient is provided with LEEP, or we should refer. Now, and if the colposcopy is normal, so we'll follow them after 5 years. Now, follow-up after 1 month with PAP and biopsy. Those who were positive and given some treatment, malignancy on biopsy, refer the patient to medical college or RCC, and treated for CIN or colposcopy normal PAP or low SIL. Then we follow up after 1 year at district hospital by PAP and colposcopy. Now, colposcopy normal, PAP, on PAP, it is HSIL. There is a high-grade intraepithelial neoplasia, or then in those cases, we need to repeat colposcopy and punch biopsy. Each punch biopsy is positive, then we should send the patient for either LEEP or cryotherapy. And if the patient is biopsy negative, then we should follow the patient up after 1 year. So the LEEP is basically loop electrosurgical excision procedure. Wherever available, we should be referring them in those patients who are not the candidate for cryotherapy. So HPV 16 and HPV 18 encode for 3 oncoprotein, that is E5, E6, and E7, that stimulate growth and have transforming properties. The integration of HPV DNA within the host genome results in chromosomal instability and favors the progression from CIN to invasive carcinoma. HIV-mediated immune suppression prevents the clearance of HPV, leading to gradual loss of control over HPV replication. And there are now 3 major alternatives for cervical cancer screening: cytology, HPV testing, and cytology HPV co-testing based on this pathogenesis. Treatment of cervical cancer includes surgery, radiotherapy, and chemotherapy. Surgery, including radical hysterectomy and lymphadenectomy, plays an important role in the management of early stage of cervical cancer. Treatment of locally advanced cervical cancer includes radiotherapy and chemotherapy. So the recommendations are: screening cytology for HIV positive women is recommended at the time of HIV diagnosis and annually thereafter. If 3 annual pap smears are negative, then it should be repeated every 3 years. Colposcopy should be performed if abnormalities are seen on pap screening. The treatment of CIN or invasive cervical cancer should follow the same guideline as those advocated for the HIV negative population. Now, coming to anal cancer, the incidence of anal cancer in PLHIV is up to 40 times higher compared to the general population, and it occurs at a much younger age, with the highest risk factor in those men who have sex with men. Anal cancer can present with rectal bleeding and anal pain or incontinence if anal sphincter is affected. The pathogenesis resembles that of cervical cancer with HPV infection, leading to anal intraepithelial neoplasia and ensuing progression from low to high-grade dysplasia and subsequently invasive cancer, just like the cervical CIN and invasive cancer. The histopathological grading of anal intraepithelial neoplasia is grade 1 when it involves the lower third. Area of dysplastic cells in the epithelium is limited to the lower third. We call it as a L-cell. And grade 2, lower 2/3, which is termed as cytological grading, is H-cell. And grade 3 means entire epithelium. It is also H-cell, high grade squamous intraepithelial lesion. Now, classification of anal cytology according to the Bethesda system. And for normal, ASC-US means atypical squamous cell of undetermined significance. ASC-H, atypical squamous cell, cannot exclude H-cell. L-cell, low-grade squamous intraepithelial lesion. And H-cell, high-grade squamous intraepithelial lesion. And CA means squamous cell carcinoma. All these are found in our national guidelines. So everybody can consult this national guideline for having remembering these stages. Now, treatment, primarily it is primary surgery has been replaced by concomitant chemoradiation, that is CRT. Concomitant chemoradiation achieves local control and sphincter preservation, but unlike surgery. Primary tumor resection is restricted to small tumors of the anal margin only. Concomitant chemoradiation therapy in HIV patients should be performed according to current guidelines for non-infected individual. And intensity modulated radiation therapy, IMART, or volumetric modulated arc therapy with a stage adapted dose of 50.5 to 59.4 gray is combined with chemotherapy in the first and 5th week, usually consisting of 5 into 1000 milligram per square meter of 5-fluorouracil combined with 1:10 milligram per square meter mitomycin C on day 1 and 29. Provided the number of CD4 cells is not less than 100 to 200 cells per cubic millimeter, and the performance status is adequate. Because of the nephrotoxic potential of MMC, that is mitomycin C, tenofovir should be used with caution, and zidovudine should be avoided in view of the possible bone marrow toxicity. Monitoring and follow-up. Response to CRT, chemoradiation therapy should be assessed as 6 to 8 weeks after completion of CRT, with clinical evaluation, MRI imaging of the pelvis, and examination under anesthesia. Clinical evaluation and review should continue every 3 to 6 months for 2 years and every 6 to 12 months for up to 5 years. Residual primary disease or local recurrence after CRT demands salvage surgery involving abdominal perineal resection of rectum and anal canal. Patients with metastatic disease or local response following salvage surgery may be considered for palliative chemotherapy. So the recommendations are that all suspected cases of anal cancer should have examination under anesthesia and biopsy. CT and MRI should be performed to assess regional nodes and tumor extension. High-resolution anoscopy services should be available for surveillance. CRT with 5-fluorouracil and MMC is the first-line treatment along with ART and OI prophylaxis. Salvage surgery should be advised for loco-regional disease persistence or relapse. Best supportive care should be advised for metastatic disease or local relapse following salvage surgery. Now coming to Hodgkin's lymphoma, is one of the commonest tumor among the non-AIDS defining cancer. 10 to 20-fold increased incidence of Hodgkin's lymphoma is found in HIV patients than in the general population. Hodgkin's lymphoma occurs most commonly with a CD4 count of less than 200 cells per cubic millimeter. The risk of developing Hodgkin's lymphoma remains while on ART, and Hodgkin's lymphoma incidence rates are higher in the first few months after starting ART. That we need to remember because it may be then viral load has not been shown to relate to incidence rates. So the viral load of HIV one is not dependent on the incidence of the Hodgkin's lymphoma. Now, characteristics of Hodgkin's lymphoma in HIV patient is that it is found in advanced stages at diagnosis, and more external involvement, especially the bone marrow infiltration, is there in HIV patient, and higher frequency of B symptoms would be there, and poor performance status. The diagnosis of Hodgkin's lymphoma mandates tissue sample biopsy. The Ann Arbor classification or Cotswold modification requires blood test, whole body PET or CT scan, unilateral bone marrow biopsy in view of the higher chance of bone marrow involvement. Stage 1 means involvement of a single lymph node group or lymphoid structure. Stage 2, involvement of 2 or more lymph node groups on the same side of the diaphragm. Stage 3, involvement of lymph node groups on both sides of the diaphragm. And stage 4, involvement of extranodal size beyond those designated as E. X means bulky disease, more than 10 centimeter or more than 1/3 widening of the mediastinum. And E is external extension, contiguous or proximal to known nodal site of disease or single isolated site of extranodal disease. A or B, there is absence or presence of B symptoms, weight loss of more than 10%, fever, drenching, night sweat. Now, management of Hodgkin's disease in HIV may be summarized as for early favorable Hodgkin's lymphoma, ABVD for 2 to 4 cycles plus IFRT. Now, this ABVD is basically doxorubicin, bleomycin, vincristine, and the carbazine. Then IFRT means involved field of radiotherapy in the involved field. Now, early unfavorable Hodgkin's lymphoma ABVD for 4 cycles plus IFRT 30 gray. And for advanced stage Hodgkin's lymphoma ABVD for 6 to 8 cycles plus minus radiotherapy. So the recommendation for recommendations, ABVD is the first line chemotherapy for HL to be administered in conjunction with radiotherapy, IFRT. Involved field radiation therapy. Now, good performance patients with relapsed or refractory HL should receive salvage chemotherapy. And if the disease proves to be chemosensitive, the treatment should be consolidated with high dose therapy or autologous stem cell rescue. HRT should be co-administered during chemotherapy and protease-based inhibitor. Protease inhibitor-based regimen should be avoided to minimize toxicities like vinblastine-mediated neurotoxicity and neutropenia. PCP, MAC, and fungal infection prophylaxis should be given after chemotherapy. Assessment of response of a treatment should be performed by PET scan and the bone marrow biopsy. Follow-up should be performed every 2 to 4 months during the first 2 years, and then 3 to 6 months for 3 further years. Multicentric Castleman disease. It is basically a group of at least 4 disorders that share a spectrum of characteristic histopathological feature, but have a wide range of etiologies, presentation, treatments, and outcomes. MCD is a relatively rare lymphoproliferative disorder that classically presents with fever, anemia, multifocal lymphadenopathy, and is now most diagnosed in individuals infected with HIV-1. MCD presents with generalized malaise, night sweat, rigors, fever, anorexia, and weight loss. Clinical examination reveals widespread lymphadenopathy, often hepatosplenomegaly, ascites, edema, pulmonary, and pericardial effusion. Laboratory investigation may reveal thrombocytopenia, anemia, hypoalbuminemia, and hypergammaglobulinemia. So we see here it might mimic tuberculosis, so we need to be cautious about diagnosing all as tuberculosis. Many of them can be multicentric Castleman disease also. So classification of MCD is unicentric Castleman disease or multicentric Castleman disease. Multicentric Castleman disease can be idiopathic, that is IMCD, idiopathic MCD, or human herpes virus 8 associated MCD, or we call it as HSV8 MCD, or polyneuropathy, organomegaly, endocrinopathy, monoclonal plasma cell disorder, skin changes, that is POEM associated MCD, which is designated as POEM MCD. Now, idiopathic MCD can be IMCD, thrombocytopenia, ascites, reticulin fibrosis, renal dysfunction, and organomegaly, which is referred as IMCD TAFRO, and it can also be non-specific. That is, it is mentioned as IMCD NOS, that is not otherwise specified. Diagnosis of MCD can only be established definitely by lymph node biopsy. Characteristic features of HIV-associated MCD are a characteristic onion skin appearance and internuclear plasmablast that express the HB8 nuclear antigen, that is LANA. This plasmablast also express high level of lambda light chain restricted immunoglobulin M, that is IgM, but are polyclonal and do not contain somatic mutations in their IgV genes. Occasionally, these plasmablasts join together to form cluster or microlymphomas and may progress to monoclonal plasmablastic lymphoma. It is suggested that histological confirmation with immunocytochemical staining for HSB8 and IgM lambda is essential for the diagnosis of MCD. Elevated serum levels of HSB8 support the diagnosis of MCD. Now, treatment is basically ART had no impact on the incidence or outcome of MCD and HIV. Rituximab-based therapy has dramatically improved 5-year overall survival for HSV8 MCD from 33% to 90%. Rituximab is used as a single agent weekly for 4 weeks in patients with adequate performance status and with absence of hemophagocytic syndrome, hemolytic anemia, or end organ damage. The combination of rituximab and liposomal doxorubicin every 3 weeks appeared to attenuate Kaposi sarcoma exacerbations. Rituximab with or without etoposide appears to be effective in HSV8 MCD regardless of HIV status. So the recommendation is histological confirmation of MCD requires immunocytochemical staining for HSV8 and IgM lambda. Monitoring for lymphoma is important as the risk of lymphoma is high in patients diagnosed with MCD. Rituximab is the first-line chemotherapy agent, and aggressive disease needs to be treated with other agents in addition to rituximab. Retreatment with rituximab-based therapy for relapsed MCD is recommended. Then plasma HSV8 level can predict relapse, and clinical monitoring for patients in remission, and it should include measurement of blood HSV8 level. Now, testicular germ cell tumor. Seminomas, germ cell tumor occur more frequently in HIV infection. Irrespective of HIV serostatus, the testicular mass must be treated with the utmost suspicion, and an ultrasound scan or MRI scan and tumor marker alpha-fetoprotein NHCG should be followed. The differential diagnosis for a testicular mass in this setting includes orchitis and lymphoma. Now, a CT scan of the chest, abdomen, and pelvis should also be performed for full staging. Now, in X-ray on the left-hand side, we can see multiple canal balls, which are quite prominently shown in the CT scan on the right-hand side. The prognostic-based staging system for metastatic germ cell cancer are good prognosis group are non-seminomas, that is 56% of cases. Here, survival is 92%. And here, the criteria, all of the following should be met, that is testis or retroperitoneal primary lesions, no non-pulmonary visceral metastasis, AFP, alpha-fetoprotein less than 100 nanogram per ml, 1000 nanogram per ml, and ACG less than 5000 international unit per liter, and LDH less than 1.5 times upper limit of normal. Then seminoma, 90% of cases, 5-year progression-free survival of 82%, and 5-year survival is 86%. And the criteria are that any primary site, no non-pulmonary visceral metastasis, normal AF, alpha-fetoprotein, any HCG, any LDH. Now, intermediate prognostic group are the non-seminomas, 28% of cases, and 5-year progression-free survival of 75%, and 5-year survival of 80% is found in this group. And the criteria are that testis or retroperitoneal primary lesion, no non-pulmonary visceral metastasis, alpha-fetoprotein more than 1000 but less than 10,000, HCG more than 5,000 but less than 50,000, and LDH more than 1.5 but less than 10 times upper limit of normal. Now, seminomas that comprise 10% of cases, the 5-year progression-free survival is 67%, and 5-year survival is 72%. And here, any of these criteria should be there. That is, any primary site, non-pulmonary visceral metastasis is there, normal AFP, any HCG, any LDH. And poor prognosis group, non-seminoma, 16% of cases, 5-year progression-free survival is 41%, and 5-year survival is 48%. And the criteria are any of the following, like mediastinal primary, non-pulmonary visceral metastasis, AFP more than 10,000, HCG more than 50,000, LDH more than 10 times upper limit of normal. And seminoma, no patients are classified as poor prognosis. All seminomas are not basically poor prognosis group. They are better prognosis, whoever is having seminoma. Now, treatment in stage 1 disease, that is seminomas or NSGCT, only surveillance is required. Non-seminous germ cell tumor or stage 1 disease, only surveillance is required. For metastatic disease with good risk factors, the cycles of standard 5-day BEP, that is bleomycin, etoposide, and cisplatin with concurrent ART and prophylactic antifungal is recommended. And patients with intermediate and poor risk disease, 4 cycles of standard 5-day BEP chemotherapy and extensive pulmonary limitation from previous infection. Alternative are 4 cycles of EP or VIP chemotherapy. The VIP is being more myelosuppressive in HIV negative patients. Then relapse disease after 2 or more treatment regimen, high dose chemotherapy followed by autologous peripheral blood stem cell transplant as in HIV negative patients. So the recommendations are surveillance may be considered for seminoma of testis in PL-HIV. Concomitant ART and infection prophylaxis is advocated during chemotherapy for testicular germ cell tumor. Germ cell tumor of the testis should be treated in an identical manner regardless of HIV status, and bleomycin may be avoided in the management of testicular germ cell tumor in PL-HIV. Then, so here's 2 regimen, that is EP, it is meant etoposide and cisplatin, and VIP means etoposide, cisplatin, and ifosfamide. Now, non-small cell carcinoma, lung carcinoma. Here, non-small cell lung carcinoma appears to occur at a higher frequency at a younger age and present with more advanced disease in HIV infected individual. And diagnosis, in addition to tissue diagnosis, a CT scan of the chest and abdomen with special attention to the adrenal glands, along with the bone scan is advocated. Interpretation of FDG PAT scan should be done keeping in mind the HIV viral load, the CD4 counts of the patient, and the consequent possibility of OI. Treatment is operable lung cancer in HIV deserves curative surgery. Higher risk of complications and recurrence are noted in HIV patients with surgery, especially if the CD4 count is low. Locally advanced disease merits chemoradiation, and patients must be on ART. An appropriate OI prophylaxis need to be put before anti-cancer therapy is administered. Metastatic disease must be treated with chemotherapy alone, and these tumors are highly sensitive to EGFR targeting tyrosine kinase inhibitor, such as erlotinib and gefitinib. Use of tyrosine kinase inhibitor requires caution due to potential interaction with ART through induction of cytochrome P450 isoenzyme and CYP3A4. No role of lung cancer screening is there in HIV as of now. This EGFR means epidural growth factor receptor inhibitor. So this tyrosine kinase inhibitor basically inhibits epidural growth factor receptor. Now, hepatocellular carcinoma. Indian studies have documented HBV and HCV to point fact 11% and 13% of PLHIV, in contrast to 2 to 3% of non-HIV population. That is, it is more commonly found in HIV patient. And diagnosis is done with sonography of abdomen and alpha fetoprotein level. A CT scan of the chest, abdomen, and pelvis is required to exclude metastatic disease, and the degree of immunosuppression doesn't appear to correlate with the BLCC staging or BCLC staging, which is Barcelona Clinic liver cancer stage. And HCC in PLHIV. Hepatocellular carcinoma patients with HIV tend to be younger, are more often HCV co-infected, more likely to present with cirrhosis, more likely to be only moderately immune suppressed, and likely to have similar Barcelona Clinic liver cancer stage at presentation as compared to non-HIV infected individual. Treatment of hepatocellular cancer. Solitary or a small number of hepatocellular carcinoma lesions are resectable, and complete resection should be attempted if the Child-Pugh score is A. Liver transplantation appear to be superior to resection alone in HIV negative patient, and HIV positivity doesn't appear to be a negative prognostic factor for transplantation. So in HIV positive patient also, we can go for liver transplantation, and is a better option than resection. PI may inhibit the cytochrome P450 enzyme system and interact with immunosuppressive agents like tacrolimus, which are routinely been used after liver transplantation. Sorafenib has been well established for hepatocellular carcinoma in HIV negative patients, and it can also be effective in PLHIV on ART. All HBV and HCV co-infected PLHIV should be advised 6-monthly AFP estimation, even in the absence of cirrhosis. Immunological and virological criteria necessary for considering liver transplant in HIV-related patient. Immunological criteria: no age-defining opportunistic infection within the previous year, and CD4 cell count more than 200 cells per cubic millimeter, or at least more than 100 cells per cubic millimeter in case of intolerance to therapy. And virological criteria is undetectable HIV viral load that is less than 50 copies per ml in the last 12 months, or effective therapeutic options for HIV infection during the post-transplant period. So if the patient is having effective therapeutic options reserved for him to be used after post-transplant period, or if the HIV viral load is undetectable in the last 12 months, then these are the virological criteria to go for liver transplant. Now, recommendations. AFP screening every 6 months should be offered to all cirrhotic patients and non-cirrhotic PLHIV with HBV or HCV co-infection. There is hepatocellular carcinoma screening with liver sonography should be offered to all PLHIV with cirrhosis or decompensated liver disease. Hepatocellular carcinoma should be treated in the same manner, irrespective of HIV status. And hepatocellular carcinoma in PLHIV may be treated with liver transplantation if feasible. And sorafenib may be used as a treatment option in inoperable cases of hepatocellular carcinoma. Now, coming to skin cancer. Primary skin malignancies are the most frequent known age-defining malignancies. The risk is higher for developing a non-melanoma skin cancer, and the ratio of squamous cell carcinoma to basal cell carcinoma in PLHIV is 1:7. Atypical features of HIV-associated squamous cell cancers are presentation at a younger age, at unusual unexposed site, including the mouth, genitalia, and perineum, multifocal, aggressive, and higher potential for recurrence and metastasis. Routine clinical skin examination and self-surveillance of the skin in older PLHIV are warranted in those with a history of skin cancer. Treatment, although conventional treatment protocols are acceptable for HIV-associated skin cancer, special attention to local excisional margin control, more extensive investigations for dissemination of disease, and more intensive follow-up are required. A multidisciplinary team sensitized to the enhanced malignancy potential and higher recurrence rate must be involved in the care of these patients. Basal cell carcinoma and squamous cell carcinoma have been reported to remit with ART. So we should immediately start antiretroviral therapy as early as possible. If it is not on ART, and if patient is already on ART, then we need to know the effectiveness of the ART, whether the ART regimen is failing or not. Now, topical imiquimod has been used for the treatment of basal cell carcinoma in HIV and is useful for the common scenario of multifocal superficial basal cell carcinoma. Imiquimod is basically immune response modifier. So the recommendations are behavioral counseling to PLHIV with fair skin to minimize ultraviolet radiation exposure and reduce skin cancer risk. Counseling on frequent photoprotective behaviors and sunscreen use to be recommended, and regular self-examination of skin and clinical skin examination is also required. Early treatment of pre-malignant lesions is important to reduce skin cancer risk. Penis precancer and cancer. Penis cancer is 5 to 6 times more common in HIV. Risk factors being uncircumscribed state, poor hygiene, smoking, lichen sclerosis, and HPV infection. Penile intraepithelial neoplasia and established penile cancer should be treated as per standard guideline with preventive and curative tissue conservation and sentinel node biopsy occupying central roles. Now, recommendations are counseling about genital hygiene and health is important to prevent penile cancer. Routine circumcision is not advocated for the prevention of penile cancer. However, examination of genitalia and circumcision should have a low threshold. Thank you. So basically from this presentation, we need to know the different types of common cancers that are possible with PLHIV, how they present and how they are diagnosed, and what type of regimen is being used to treat those cancers so that we can choose a proper antiretroviral therapy to limit the drug-drug interaction, side effects, and different toxicities. And we should be able to refer the patient in time. And this is basically the message for the people who are practicing in the ART center. Now, thank you very much. Swetaji, over to you.
Thank you so much, sir. It was a lengthy session. Yes. Any questions from the participants? Please feel free to put your questions in the chat box. You can also unmute your mic. Any questions regarding HIV and malignancies? So I don't think there are any questions. Can we quickly run the feedback form, sir?
Yes, please.
Kiran, sir. Thank you. The feedback form is now visible on your screen. All the participants are requested to please fill in the answer the questions. Requesting all the participants to please fill in the feedback form. Kiran, sir, we can end the feedback poll. Thank you, sir. Thank you for facilitating this session.
Most welcome. Bye.
Thank you to all the participants for patient listening. We have 2 more sessions left in the series of the National Guidelines for HIV Care and Treatment. So we plan to finish the sessions in the next week. So please stay connected. Thank you, sir. We'll end the session now.